she's
That's
got a
fine.
seat there, and then we'll go from there.
Can you see one? Yep.
It's not worth looking at. So, all right, I will. We'll get started. My name's Lenny Parker. I'm from Northeast Pharmacy. I'm one of the owners of Northeast Pharmacy. I'm a pharmacist. Been in the long-term care, assisted living business for about 24 years. This is all I think I do anymore. And people ask me what we do, and I tell them I sell drugs to old ladies. And that's really basically what we do. It's funny, you know, the baggies we send our packets in. You guys don't know, but the villager would know.
Yeah.
I buy them at Sam's, so I go through and I've got like 10 cases of these baggies, and so everybody looks at me like, "What?" I said, "I just sell drugs," and people just kind of they shy away, and but that's what we do. I'll give you a little bit of intro of what we're doing here today, my background, and what we're going to try to accomplish. Again, I'm a pharmacist. I've been a pharmacist for 31 years. If you want to do the math, I'm 56. People, I always see the wheels turning, so. But I've been in again the long-term care business for about 24 years, and I've been on several state regulatory boards. I was 10 years on the State Board of Pharmacy. I was on the Board of Optometry's licensing for pharmacy and glaucoma credentialing. I was on the board for licensing nursing home administrators. I'm still on that board. A bunch of local civic type boards. I'm on a committee with the Attorney General's office. It's called the Elderly and Incapacitated Death Review Committee. I call it the Death Squad, so it's, we meet tomorrow as a matter of fact, but it's by far the most fascinating thing I've ever done. There's a group of people as part of the Attorney General's office, and we look at folks who have passed away for one reason or another that shouldn't have. And then we say, what can we learn from this to educate the public to prevent these things from happening in the future? So it's kind of been eye-opening. I'll share a couple things from that as we talk today. I have 4 boys, wonderful boys, and I'll bring them up, and a wonderful wife, and I do a lot of illustrations with my wife through this, and I want to say right up front, she knows them all. Okay, I'm not talking out of school, although I would, but I'm not in this case doing that. So we will, this is a 4-hour program. I said some of you were here, some of you weren't. I can talk for 4 hours. You can't listen for 4 hours. Okay, so we'll take a couple breaks throughout the course of this. And we will finish on time, if not a few minutes early. My oldest son is a minister, and the only advice I ever gave to him was, nobody gets mad at you when you finish early. Okay? Go 2 minutes long in your sermon, oh boy, you'll hear it forever. So that's kind of the only advice that I've given him. In your packets, there are copies of the slides, handout with the slides if you wanted to take notes. I don't think you'll need to, but that's totally up to you. There's a handout on infection control. How many of you have had infection control training? Okay, some of you have, okay. Usually most people have, so it's kind of just a refresher from an infection control standpoint. There's a handout on pharmacy calculations. Now, nobody likes math. I've learned that over the time that I've taught this course. Nobody likes math, but me neither. But I want to just give you a few things on dosing. Things you probably never will have to calculate, but I want to give you a little bit of feel about pharmacy dosing and how we calculate some things. The handbook that you have, this is yours. So as we start to talk about medication in there, if you want to make some notes in there, that's fine, or whatever you want to do. That's fine. The reason we're here is you guys are governed by either 2 sets of rules by the State Healthcare Facilities Administration. Those are the people who write the rules on how you have to run your business. Okay? Now there's 2 sets. There's the 804 rules for residential care, 805 rules for assisted living. Okay? You fall either under one of those sets of rules. Okay? Here's the rules if you really get bored. There's 45 pages of rules that the state looks at when they come in and survey your building. 7 pages of that 45, which is about 13% of those rules, speak to medications and how you handle medications in your facility. So the state is very keen on what you do with medications. Okay, so they look at it very hard, and it's one of the reasons that we're here. Within these rules, there is a section that talks about what we're doing today, the course. It says that if anybody is going to handle medications and assist with medications in an 804 or an 805 building, they have to have a 4-hour medication course. Okay? That's what we're doing here today, is that 4-hour course. They spell out specifically what we have to cover in the course, so it's very straightforward what we're going to cover based on what they tell us to cover. How are you, is anybody an LNA? Okay, you're an LNA, okay, you're an LNA,
Medical assistant.
okay, medical assistant. What happened was when these rules were first published in 2008, was the rules say that you, with this 4-hour course, could handle medications and observe medications with your residents. If you're an LNA, you are also licensed by the State Board of Nursing. And the State Board of Nursing said you cannot handle medications. So there was a real conflict between the Board of Nursing and the Healthcare Facilities Administration about who could do what. And so there was a battle that lasted close to 18 months between the two agencies when finally Margaret Walker, who's the head of the Board of Nursing, said we have to straighten this out. And she called the meeting together. I was at the meeting, there was surveyors at the meeting, other administrators at the meeting, and she said we realized we've been wrong, that people who are not LNAs can handle meds, but LNAs can't. And so we're going to make a new designation for an LNA called an LNA MC, or Medication Certified. You need to know this, okay? The LNA MC designation is exclusively for assisted living and residential care, okay? It has two pieces to it. It has the part of having the program, and secondly, whatever standards your home has, as far as handling medications, you have to do that. You guys do too. You have to pass whatever standards you have in your home. And then what happens is you make a copy of the certificate that I'm going to give you today when you finish the course, and your administrator has to notify the Board of Nursing that you have taken the course, you have met their standards, and the Board of Nursing will then designate you as an LNA MC Medication Certified, okay? That designation is only specific to the home that you work in, okay? So if you leave and work in another home, that does not follow you, okay? However, the course does. You don't have to repeat the course, okay? What they were trying to accomplish was, okay, the 4 is core knowledge, but every home does things a little bit differently. So when you go to that home, we want you to make sure you understand how they do things, how they document things, and all of that. So if you leave a facility and you go to another, that new administrator can still use the copy of the certificate that I'm going to give you, and don't lose these. Make a copy for your administrator, but keep these certificates. And then say, he or she has now met my standards in my home. So you can be an LNMC for that new home at that point, okay? Again, this is a one-time shot on the 4-hour course. I have people who have shown up for a second time, and I'm thinking, wait here, the jokes are the same. It's going to be a long 4 hours for you. But you don't have to repeat that. I will give you a certificate at the end today, and I would make sure you keep good care of that, because it does say that you have in fact have that 4 hours, okay? Questions on that? Okay. So what are we doing? Okay, the program itself, on the first slide, it says for people who are not nurses, medical nursing assistants, who assist residents with self-administration with supervision, self-directed administration, and nurse delegation. The 805 rules, it's funny, the 805 rules say that this course has to be taught by a nurse, practitioner, or a pharmacist, okay? The 804 rules don't say that, so whoever's your cook here could probably teach the course for you, I guess, with the 804s. It has to cover prescription and non-prescription medications, and then this is specifically what the rules tell us we have to cover. Infection control, hand washing, the 5 rights, documentation requirements, general categories of medications with their desired effect and potential side effects, medication precautions, and interactions. So I'm putting this together, and one of my pharmacists says, okay, so for 4 hours, you're going to teach every category of medication, how they work, and what their side effects are, what it took me 6 years to learn. And I said, yeah, I guess I am. So that's in fact what we have to do, okay? But the beauty is, when I was looking at putting this program together several years ago, I'm thinking, how in the world am I going to make so many slides of every single category of medication? And then I happened upon this book. And the book literally breaks everything down by medication category, and it tells the side effects. So what we're going to do, and we spend probably an hour, 45 minutes, we literally will cover each class of medications. I'll give you some great tips on each class, what to look for. I'll tell you a little bit how they work. I won't make you a pharmacist, I promise. I don't remember, that's why. But I know generally how things work. We will really spend some time on the drugs to treat dementia, okay, for Alzheimer's and behavior issues. We'll spend a fair, when you leave here today, you will know exactly how Aricept works. You'll know exactly why the person's drooling. You'll know exactly why they're incontinent. You'll know all of those things with those kinds of medications, and you'll know it very, very well. I'll spend a little bit of time talking about Alzheimer's, because really that's where we live. We live in this business for the most part, and dealing with dementias and those kinds of things with our folks. So you'll have a great understanding of those medications when we get done. I do have a separate 2-hour program on Alzheimer's if you're interested. And one other disclaimer: the slides that you have and the handout that you have, I don't know how to make those. Okay, my youngest son is a whiz with this kind of thing, so he does all of my slides. So there is one slide that was out of order. It's now back in order on my slides, but it's out of order on the handout. Okay, I don't know how to redo all that. But anyway, he's funny. He's my youngest. He's got 5.5 more weeks of pharmacy school, and he'll be my youngest will be done. But he's one of those kids that fall into everything, just it always comes out right. Sometimes you just want him to fail once in a while, just to damn feel. But anyway, he does my slides. I told you I have a 2-hour presentation on Alzheimer's disease that he does. I literally just write them, and then he punches them in and does all that stuff, and I know what buttons to hit here. So he calls me during his 4th year of pharmacy school, and he says, "Ted, you won't believe it." He says, "We're going to do this group project. It's a 2-hour project we have to do, and do a presentation." They chose 6. They put us in groups of 6 to do these, and assigned us topics. He says, "They gave us Alzheimer's." He says, "I said, I'll do the PowerPoint." He already had the stupid thing on his computer, so that's the kind of kid he is. He's a lot of fun, but boy, sometimes just wanted to fall. Is that on tape? Don't ever let my son see that. He's coming into the business this summer, so don't let him watch this tape, okay? He'd laugh at that, I'm sure he would. So if my phone goes off, it's my youngest texting me from wherever he's at today. So, okay. So that's what we have to cover in our 4 hours together. It seems like a lot, but it'll go quick, as quick as I can make it. I'll try not to be. There's nothing worse than being bored and sitting there. And I know when people get bored, so I will try not to bore you. Okay. So we start off with just some definitions. Okay, what's a prescription medication? It's obviously a drug. A prescription has to be written by a licensed practitioner, such as a doctor or a nurse practitioner. New Hampshire has some of the most liberal rules and laws when it comes to who can write prescriptions in the country. Okay? In New Hampshire, a nurse practitioner doesn't even have to work with a doctor. A nurse practitioner can be totally on their own. That's really rare. Physician's assistants can also write prescriptions. Optometrists, the difference between an ophthalmologist is a doctor who's specialized in eye care and does surgery and all that. Optometrists, and my friends who are optometrists will shoot me when they hear me say this, but they're the guys that test your eyes. Okay? They also have prescription rights in this state. They can also treat glaucoma. They can write prescriptions. Naturopathic physicians can write prescriptions. There are a lot of people in this state who can write, which is unusual when you look at it nationally. Okay? Prescription order has to be implemented on behalf of the patient exactly the way it's written. Now that's true for non-prescription items also. Obviously it can't be purchased without a valid prescription. It has to be packaged by a licensed pharmacy or samples, doctors or prescribers. I'll say doctors, you understand, I mean the other type of people who can write too. Has to be packaged by a licensed pharmacy or sample. There is a rule about samples that they have to be labeled, and we'll talk about that a little bit later. And ultimately, the resident still has a choice of refusing the medication. Okay, residents' rights trump everything. Okay, now I always talk about this, and especially in our environment, when somebody says, they refuse their meds. Of course, you can go back 2 minutes later, and they may or may not remember they refused them just previously, and say, "Would you? Oh, I'll take them now." Okay, so make multiple attempts if somebody refuses. The other thing is that we get into these type of environments, more so on the nursing home side, where somebody goes into a facility and all of a sudden they think they have a right to any medication. It's usually the family member who's Googled on the internet and comes in and says, "Mom needs this and Mom needs that, and I'll bring in this," and you know what I'm saying. Even if the family decides Mom needs all these things from the health food store or for somewhere else, they still have to be signed off by the person's prescriber. Okay? You can't family just can't walk in. It still has to be signed. You're legally in charge of that, and without a written signature, you can't do that. Okay, I'm clear with that, because sometimes all of a sudden the internet has made everybody doctors, so it's pretty amazing. Okay, so they don't have a right to everything. Okay, just like you and I don't have a right. I can't walk in. Well, I probably could and say, "Give me some Ambien from the pharmacy," but you couldn't do that, just because you have to have a legitimate medical cause for having everything that's in your chart. Okay. Over-the-counter medications. Remember, these are still drugs. Okay, I told you I've been in this business 31 years. Lots of stuff that were prescription items when I started in this business, and now over-the-counter. Okay, over-the-counter stuff is still dangerous. okay? If it's not taken the way it's supposed to be taken, it's dangerous. Okay, the drug Prilosec for stomach ulcers, when that first came out, that drug was restricted to 6 weeks because they thought for sure you'd have gastric erosion and that it would cause cancer. Okay, so it's important. Anybody know you probably do, but the #1 drug for liver failure in this country? Tylenol. Okay, that committee I'm on with the Attorney General, we're doing a PSA, public service announcement, based on not taking too much Tylenol. Okay,
Well,
everybody thinks
she's
it's
a good
benign.
case study for you.
Oh,
She's
right.
got all
I took
kinds
too
of
much
stomach
Advil
trouble.
and now I have severe erosive gastritis.
Yeah, I was going to say, your stomach's gone, and also you're lucky you got your kidneys. Okay, because Advil can really blow out the kidneys. There was a professional basketball player blew out his kidneys from too much Advil. My third son is an Army officer, and he went to West Point, and he called me one time. He said, "We just finished a 7-mile march. We all took 6 Advils." I said, "What are you? You guys are the smartest kids in the country. What are you, stupid?" You know. So just because you can buy it without a prescription doesn't mean it's not dangerous. Okay, you got to take it the same way. Again, you have to have approval from the practitioner in order to use them. If somebody comes in with an over-the-counter bottle, they're folks, and that's perfectly legit for family members to bring things in like that. They still have to be, it says they have to be marked with the name of the resident using the medication, okay? So make sure you don't just have a big bulk bottle of Tylenol for somebody. Legally, unless you're a licensed to administer, which you guys are not, somebody licensed to administer is a nurse, an RN, LPN, or an MNA, which is an LNA with 80 hours of experience. You can't use stock bottles, okay? Everything has to be patient identified, okay, with that. So make sure their names are on the containers. The state will look for that, okay? Make sure
I'm not
it's-
clear on what you just said. So in other words, if a family member comes in
Yeah, you just have to write, yeah.
with a bottle of Tylenol,
Yeah.
it doesn't have to go through their physician.
If they haven't, I'm just saying they can
They have to
supply,
have an
they can
order for
supply, they
that.
still
Okay,
have
they
to.
can supply
There has to be,
it.
they can
still have-
supply
yeah,
it,
they still
yeah.
have
But
to
there
have
has
the
to be an order.
There still has
Okay,
to be
yeah.
an order.
Just wanted to be
Yeah.
clear on that.
And you have to write their name on that bottle.
Oh, right.
Okay, you have to Mary
All right.
Smith, okay? So you
Yeah,
Mhm.
you have to do that.
They just couldn't bring it in because they want mom not to
Yeah,
take
yeah.
Tylenol.
Exactly.
Yeah,
Yeah,
or
that couldn't
biotin or
happen. Right.
something they just read about that, you know, I
Right.
think that would help my mom.
We just
Okay.
had a huge
That's what I
situation
thought.
with cough drops. Everybody was like, "Oh, we have to bring in cough drops," and like, we need orders for those.
So,
You know, and it goes as far as medicate. If the word medication is even on like
yeah.
powder,
Halls
medicated
Halls
powder.
medicated eucalyptus,
Yeah.
yeah.
Oh yeah.
Foot
It's,
Yeah,
powder
yeah.
or something
Oh,
like
yeah.
that.
That's how
Really?
Yeah,
ridiculous
foot powder
it
is
is. Yeah.
antifungal usually,
Yeah.
so they'll want something,
Right.
you gotta have
Right.
everything,
Everything.
okay?
Yeah.
So, yeah. PRNs obviously are meds that aren't used routinely, only as needed, obviously. The rule states specifically that, and this is right from the rules, that every PRN must have a physician's or a pharmacist order. Now, pharmacists don't write orders, okay? I can't write an order for your resident. But I can help you with the indication because it says they also have an indication, have to have an indication for use. That simply means you can't have a Tylenol order that says take two tablets every 4 hours as needed. It has to be as needed for headache, for pain, for fever, okay? It has to have that indication. It has to give precautions or limitations to the use of the medication and the maximum allowed dose in 24 hours. Now, when this rule first came out, I had people calling me saying, "Hey, it doesn't have, you don't tell me how many I can use in 24 hours. I said, "Well, read me the label. It says 1 tablet 4 times a day is needed for headache." I said, "Well, how many times can you use that?" 4. Okay, I don't have to say maximum 4 in 24 hours. If it's part of the directions, that counts. Okay. Here's what you can't have. You can't have a loperamide or Imodium order that says take 1 capsule after each loose stool. You can't say that. It has to say after each loose stool, maximum 4 capsules 24 hours, 8 capsules 24 hours, or something. Okay. It can't be open-ended like that. That's what the rule is trying to prevent. Okay. Same thing with nitro. Usually we see my nitro is how many of those you can. It's needed for chest pain. It's usually 3 doses, and then they go to the hospital. Okay. Allergies. Okay. I'll pause here a little bit because drug allergies can be deadly. Okay. You really need to know if your folks have true drug allergies. Okay. Because what can happen, people with a true drug allergy can die really quickly, or they can go into anaphylaxis really quickly. Their throat can swell up and they can stop breathing really quickly, okay? So you need to be aware if your folks are in fact allergic to any medications, okay? And what we find sometimes, more often than not, is that what you have in your chart may or may not be a true allergy. It may say, I'm allergic to Advil because I blew my gut out with it because of my stupidity. You know, I mean, those kinds of, just kidding. those kinds of things. Or they've had aspirin that's upset their stomach. Okay, that's really not an allergy, that's a side effect. Okay, if somebody's truly allergic, you'll see a skin rash, a hot red skin rash usually, hives, and then the throat starts to swell. Okay, so that's a true drug allergy. And unfortunately, we don't always get good histories from folks. I had a list of allergies, like 18 allergies on this resin. I said, this can't be right. I said, the one was prednisone. You can't be allergic to prednisone because prednisone treats allergies. I mean, you just can't be allergic to it. So I said, I called the facility, I said, can you give me a new list of allergies on this person? So I got a handwritten list by the resident, faxed back to me. First one said, allergic to all seafood, except for haddock and lobster. And the whole list kind of went like that. So know what really is a true allergy and what's not, because it can be really deadly. And sometimes you get cross allergies. 2 of my 4 boys are allergic to penicillin, and they're allergic across the board to every single penicillin. So even Keflex and all of those things is usually just a small crossover. But make sure, mostly antibiotics is what we see allergies to, or things that are related to antibiotics that have like a cross allergy to sulfur. Those are the things you really will see allergies. Watch for those hot rashes. The other thing about drug allergies is they don't always happen the first time you give somebody a medication. More often than not, they don't. Because what happens is with a drug allergy is your body builds up antibodies against the drug. And if you give somebody amoxicillin for 10 days, sometimes that 10 days just isn't a long enough period of time to build up a level that's needed to see a reaction. So what happens is you give somebody amoxicillin, they're fine. You give it to them a year later, and they built that titer of antigens, and all of a sudden they're allergic to it that second time around. So always be aware every time your resident gets a new medication, just watch them for the first 36, 48 hours to see if anything's going on. Or later in the regime if it's a short-term order, because it may build up to that. Okay.
Lenny, do you check the list of allergies
Yeah,
before
we do
you
it
fill?
yeah,
Okay.
absolutely.
So,
Absolutely.
okay.
But you have people go to the ER
Right.
sometimes, and
Right.
one of the reasons we have some emergency kits in places, and I really hate those because lots of times people just pull a drug from them and not even think about and don't have that check.
Mhm.
So yeah, we absolutely, our system checks all of that stuff.
Okay.
So, yeah. Samples, again, I said that the rules allow for people to have samples from their prescriber, but they have to again be labeled, and the rule says they have to be used in accordance with the order and labeled by the practitioner. Now, no doc's going to write their name on it, okay, just so you know. The administrator or their designee with the resident's name. Essentially, it means anybody can write their name on the box and make sure it's on there, okay, whenever they have pharmacy samples. Okay, this is the slide that's out of order on your handout, okay? Just always read the label, okay? The label gives lots of information, the name, the drug, the strength, all of those things, how often, and any indications for PRNs and those kinds of things. Somebody has an order for a PRN. One of the things that you want to be careful of is if they take that PRN on a regular basis, okay, that person needs to be reassessed and checked. Did I tell you I'm allergic to cats? If I
Are you
start
really?
itching,
Are
only if they're on my lap. It'll be fine running around. Okay? I would have already started reacting because there's dander in the room no matter
Yeah.
what. So, but with a PRN, if somebody needs something for pain or some other PRN, make sure they don't have to wait for it. Okay? In the nursing home environment, there's rules that say if they use a PRN more than 5 times in 7 days, they have to be reassessed because something's going on. And maybe you want to give it to them on a regular basis so they don't have to be in pain before they request it. So somebody's using a lot of PRN, the next time they go out to visit the doc, say, hey, can we schedule this? Or is there something else we can give them that might work a little bit better? So just be aware of that. Okay. Precautions and interactions. This is just 2 other definitions that sometimes get confused. But a precaution that we give you on a med is a predictable event. We know that if you take a Vicodin, you're going to get a little loopy. So we'll tell you don't drink alcohol with it. Okay? We know that's going to happen. Or if you take Advil and you want to take it with food because it can upset the gut. All of those things, we're going to tell you, those are precautions. Predictable events that happen with every time you take a drug. Prednisone, we know it's going to hurt your gut if you don't take it with food. Okay? An interaction is different though. An interaction is defined as the interaction between one drug and another substance that may or may not be a drug that prevents the drug from performing as expected. Okay? We know how a drug's supposed to work. Okay? If you give another drug, now that interaction may increase the way the drug works or it may decrease the way the drug works. It may go either way. You might have more side effects or something might happen. And the way that drug interactions occur, there's a couple different ways. Either we prevent the drug from being absorbed or we prevent the drug from being excreted. okay, one way or the other. So it hangs around longer, or it doesn't get absorbed, or it's metabolized faster. So, for instance, the classic interaction, if somebody takes a tetracycline or a not doxycycline, it's not an example, but tetracycline. If you take tetracycline with milk or with Maalox, the milk binds with the tetracycline in the stomach and you don't get any absorption. It doesn't work. Okay? It doesn't hurt you, it just doesn't work. Okay? That prevents the absorption. You and I get rid of drugs two ways. Either the kidneys grab them and we pee them out, or the liver metabolizes them and they go out in feces. Okay, that's how we get rid of drugs. And I always get on my soapbox a little bit here because there's all of these studies that show medications in the water system. You've all heard of medications. So they changed the way that we have to destroy meds. You're not supposed to flush meds anymore, although most people still do. And you have to dissolve them, put them in kitty litter or coffee grounds or some way to make them inert so they don't go into the sewer system. But they can stop every single person from doing that, and you're still going to find virtually the same amount of drugs in the water system, because that happens because you and I take a medication and we pee it out. I mean, that's exactly what happens. So you flushing 2 Ativan down the toilet is not contributing to the problem. That really is just normal metabolism within folks, okay? So anything that increases the way we get rid of it, we do create interactions. The drug Augmentin, which is an antibiotic, it's a combination of amoxicillin and clavate. The clavate prevents the amoxicillin from being excreted, so we get a higher drug level of amoxicillin. It works really, really well. Other times we don't want to do that. The drug Zyprexa or olanzapine, that's used mainly for schizophrenia, but we do see it for some behavioral things in our folks. If you smoke cigarettes, nicotine stimulates the enzymes in the liver to metabolize that drug faster. So if you think about somebody with schizophrenia, they all sit there and smoke butts like 20 times a day, and what they found was they had to increase the dose of those folks who smoked on Zyprexa because the nicotine was causing it to be metabolized and get out of the body quicker. And so then they found that people they'd go to the medical doctor, the guy would get them to quit smoking, and now they were toxic on the Zyprexa because they've upped the dose around that. So you got to be careful around that. A lot of interactions aren't clinically relevant. You seen the sticker that says, "Don't take this with grapefruit"? My mother's 84, and she called me one day, "I can't have my grapefruit anymore." She had an eye drop in the pharmacy, put that on there. And I said, "Are you kidding? You have to eat a case of grapefruit at the same time you're taking the med." So the relevance of that is not that great. So anything that increases or decreases, that will
Is that
happen.
the same with like an ADHD medication and orange juice?
Yeah, some reason the same thing. It will stimulate those enzymes to metabolize that a little bit.
The one glass won't hurt you.
No.
Good to know.
I've never heard of that one.
Okay.
I've never heard that. I'm
Yeah,
not
it does
ADHD
do
mental.
that. So it's not really clinically relevant. Okay. These are the definitions from the rules of your residents. The state defines people how they take their medications in 4 different ways. Okay. The first are residents to to self-administer without supervision. Okay. That means that the resident is completely independent with their medications. Okay. We don't have a lot of these folks. Okay. But we have some. Okay. Now that means they can order them, they can take them. You don't have to do anything with them. Okay. The second is a similar category, and that's the self-directed administration of medication, which simply means the resident is cognizant, but they have a physical limitation that prevents them from self-administering. For instance, you've got somebody who's very cognizant, knows what they take, when they take it, how to order it, do all those things, but they may have arthritic fingers. They can't do their eye drops well, so they ask you to help them with their eye drops. Okay, we don't see a lot of these residents. Okay. And self-directing means they're directing you. We'll talk about that in a minute, okay? Go ahead.
Question on that. I have, a resident who has that problem. She can't do her eye
Mhm.
drops, so
Yeah.
it's not bad if she tells me, can you hold my hand?
Absolutely, you can do that with her together. You're assisting and observing, okay? Here's just another tidbit. If you ever call the Board of Nursing with a question about what you can do or can't do, don't ever use the word administer, okay? Observing, okay? I had somebody, again, I've taught this class way too many times, and somebody called the Board of Nursing, and they called me and said, they told me I couldn't do this. I said, what are you talking about? So I called, and my contact at the Board of Nursing said, well, she said administer. So the minute you say administer, they shut down, okay? I work, I observe people with self-administration. Can I do this or whatever? Don't ever use that word if you happen. I don't know why you would call them, but if you ever call them, then don't ever use that word, because it's really observation, not administration. And they are very picky about that, okay? And the final category are residents to self-administer with supervision. That's where 99% of our residents are. And that means the staff assists the resident but only supervise. You don't quote-unquote administer, okay? So for each of these categories, you need a couple things, okay? If somebody's a self-administer, they need an annual order, written order from the prescriber that authorizes them to self-administer, that authorizes what can be stored in the room and the meds that can be stored in the room, okay? You don't have many self-administers, okay? With these folks, you don't have to chart. They are totally on their own, okay? It's as if they're totally taking their medications, okay? For a self-directed, again, the same thing. You have to have that order from the prescriber, and that, and then they verbally can direct you to assist with, and this is right from the rules, preparing the correct dose of the medication by pouring, applying, crushing, mixing, or cutting, and assist the resident to apply, ingest, or instill the dose of the medication. Now with this resident, okay, they are directing you, which simply means you can't walk in at noontime and say, Mary, it's time for your Timoptic, let's do it. Mary has to call you and say, hey, it's noontime, it's time for my Timoptic, can you please help me instill this in my eye? Okay, that's the difference, okay? Or she can say, here's my hydrochlorothiazide 25, could you please cut that in half for me? Okay, you can't walk in and say, hey, it's time for me to split that for you, okay? So that's the difference. There's no, I used to say, I never see residents like this, but every time I say never, somebody pops up and says, oh, I've got one. So they're few and far between, okay? This is where you live, okay, and this is what you can do, okay? This is self-administration with supervision, okay? You remind the resident to take the correct medication at the correct time. Place the medication container within the reach of the resident. You can open the container. You can, in the case of packets, open the packet with them, okay? And then you need to remain with the resident to observe the resident taking the appropriate amount and type of medication as ordered, and then record on whatever document you use to record that they've taken that medication, and document any side effects or anything like that. The rules specifically say you can't handle the medication in any way, okay? You have to just assist them, okay? And I always say to folks, this is my feeling of how you should do this, okay? And I think it's pretty standard practice. But the first thing is that you always dose from the medication record, not from the bottle or from the packets, okay? The medication record is the legal document telling you what the resident is to receive or what they're taking, okay? You then go to that record, you see what they're supposed to have at 8 o'clock in the morning, you take whatever number of meds, you go to the resident, you help them take them, hand over hand, or however you do that, then you come back and sign off on the medication record, okay? I know that people say, hey, it's 5 o'clock, it's time for Mary's warfarin, and they walk in with a bottle and give her a warfarin, okay? And especially when you get so used to knowing your people, you know what they take, you know when they take it, don't do that. Because it could have been at 3 o'clock that changed. And you go to the record first, and the state will look at that. They're going to watch you say, okay, how is she going from the record? How are they doing? Because the surveyors cornered me at the last trade show back in October and said, hey, walk me through what you teach. And I told them exactly, and they said, good, because they don't want people looking at a bottle and going in the room, okay, because things change, okay, and you need to know that, okay, and we'll talk about some other reasons you wouldn't do that. But always, the record, the drug, watch them take it, and then come back and sign off on it. Somebody says, well, what if they cheek it? And I said, well, common sense says, you know, watch them to make sure they take it. You do, people spit things out afterwards. I mean, few and far between in this business, but you do have those folks like that. So just make sure you're confident that they did in fact take the medication, because you're signing a legal document that says they did, okay? And then the rules always also say, now you don't have any nurses in either one of these buildings. I don't believe nurses, you don't have nurses, okay, but, or M&As or LPNs, but the rules do specify what they can do also. So if you're ever in another situation where you're working with a licensed person, the rules say that they have to prepare immediately prior to administration. The medication has to be prepared, identified, and administered by the same individual, which means this: if you're in a building and a nurse has a cup of medication for Mary Smith, and all of a sudden gets diverted and say, hey, could you go give this to Mary for me? Your answer is absolutely not. Okay, they can't. Yeah, that would be a total violation of rules. It also says a nurse can't prepare all the meds for everybody at once and walk down the hall. You know, in the old days we used to carry a souffle cup holder down the halls to pass out meds. That can't be. One at a time. You really should do one at a time when you're doing residence, okay? Just a personal bias, but I really feel that a focused administration or observation is really, really, really important, and one person at a time, start to finish, okay? I was a big advocate of folks like you and folks like LNAs becoming MNAs, because if somebody's focused totally on giving that medication without interruption, I think they do a better job. I was the Board of Pharmacy's liaison to the Board of Nursing for 10 years, and one of the things we wrote were the rules around MNAs. And there was a lot of pushback on that, and I said, if you have somebody who's focused on doing that job with the appropriate training, I think they do it better because they're not interrupted, hopefully. You know, a nurse gets pulled in 8 different directions. But focus on doing one at a time. Make sure you do that and you know what you're doing. Okay. Nurse delegation, again, you don't work on it, but someday you might, so I covered it anyway. Oral meds only. It says that you have to document in a personnel file of what's going on as far as the evaluation, how that nurse has evaluated you. If there's must be ongoing evaluation. You need to, every year, whoever your supervisor is should be writing something down that you in fact are still up to speed doing this and that you're doing a good job at it, so on and so forth. You have to have that review every year. And anything that says the task has been rescinded. Now if you screw up enough and they take it away, hopefully that's not going to happen, but there should be some documentation. No, you can't handle meds anymore. Okay? And then there's specific meds that need to be administered, the dosage routes, whoever's been delegated to, and then the nurse's assessment that a resident's stable. Anybody know what the Board of Nursing's definition of a stable resident is? Nobody does, so I'm going to tell you anyway. Okay? A stable resident is a resident who has a predictable outcome. What does that mean? It means we know what's going to happen. So under that definition, a hospice resident is considered a stable resident. Fortunately, you know what the outcome is going to be for that particular resident. I get questions, hey, I've got a hospice resident in my facility now, can I give them their morphine? I said, you better be giving them their morphine because we don't want anybody in pain. Okay, absolutely can handle it. What's not stable? Somebody whose blood pressure is going like this, or a diabetic whose blood sugars are all over the board, okay, that we can't predict what's going to happen with them, okay? So they need to be stable, okay, as long as we know what's going on, okay? Okay, let's take a minute, we'll talk about the 5 rights, okay? You have a very simple task, okay? That task is get the right resident, the right drug, and the right dose at the right time via the right route. Do that, we're happy. Pharmacy, we have one more, and that's the right to get paid. Okay, because lots of times you've seen it, we go to fill a prescription, the insurance company says, prior authorization. What does that mean, prior authorization? What happens is, and it's happened in the last probably 5 to 8 years, no longer than that, probably 10 years now. But drugs got very expensive in the late 90s. All of a sudden the pricing of drugs went crazy. And so insurance companies on high-priced drugs said, we want extra documentation from the prescriber saying why this resident needs this medication and why they can't use this medication. Okay? It's totally about driving the cost down. So if somebody was getting Zyprexa, which now went generic, but at $500 or $600 a month, Abilify 20 milligrams, $800 a month, they wanted justification. Why can't you use generic Risperdal for $30? And that's what they're looking for, or high-end medication. So we'll fill a prescription. Insurance companies say, no, we're not going to pay it. We'll call you and say, we fax a doctor, but we can't send that until, in fact, they do it. Puts you in a quandary because the rules say that you have to have available to that resident within 24 hours every order. Okay? If you document that, and we had discussions with the surveyors about that, document what's going on, you'll be okay. But make sure that they just don't walk in and say, hey, you got this order on Thursday and you didn't get the med till next Wednesday, what happened? Okay? Make sure it's documented. As long as you say, Mary's drug is not approved by her insurance, working towards that, and make that note. Make sure that's in the chart somewhere, or you could get in trouble. Okay? So let's talk about the right resident. These things seem so simple, but let me tell you something, they're not that easy. Okay? They really aren't. Okay? You need to make sure you got the right person. Now you folks all work in rather smaller facilities, okay? But things happen. Okay, you get busy, focus like we've talked about, and somebody gets the wrong drug, okay? So make sure you know your residents, okay? You could kill somebody by giving them somebody else's medication, okay? Be mindful that maybe one resident or another one with very similar names. Don't count on the residents to know their names. Are you married? Oh, I'm married. Are you Doris? Yes, I'm Doris. I mean, you know, that can happen, especially when you're new to a facility, okay? Take your time, okay? Don't, you know, always read the name of the medication and always ask yourself, have I got the right person? Okay, it's not gonna hurt you to take that extra 15 seconds to make sure you get the right person, okay? Let me give you just a few examples of wrong residents getting wrong medication, okay? The first time I ever saw this happen, I was in a nursing home doing consulting pharmacy, and I was sitting at the station, and a nurse happened to come up to the counter, and she was green. And she said, I just gave so-and-so Tagamet that belonged to so-and-so. And she looked at me with what's going to happen, and you know Murphy's Law, the person who got the drug in error, her son was literally standing at the counter. And he was a good guy. He was one of those guys that was involved with mom's care. He knew what was going on with her, and he's one of those that was there a lot. I had got to know him, and I was only there once a month, and he just looked at me, we talked about it, and said, you know, mom's stomach's probably going to be okay. Don't, you know, it's not a big deal, okay? I got a call one Sunday night from a facility, and they said to me, I just gave 6 medications to the wrong resident. 6. Okay, now, once I talked her off the ledge, I said, okay, let's walk through this. What would be the first thing you would think of when somebody got the wrong medication? What's the first thing you want to look at, based on what we've already talked about today?
Allergies.
Perfect, okay?
Allergies.
Let's go. The first thing I'm going to do is go back to that chart. Is there anything she's allergic to that I just gave her? Okay, that's the first thing you want to think about. Secondly, I'm fortunate I have access from home, so I booted up my computer and I said, let's check for interactions, okay? Any interactions between what she's taking, what she's eating, that will affect this medication. There weren't. And it worked out okay. And then I said to her, I said, now you gotta do the right thing, okay? Whatever procedures you have placed, you've got to notify your supervisor or whatever, and make sure the family, whatever your procedures are, follow them. Okay, don't hide anything. I thought I was talking to my boys when they were teenagers. Okay, be honest up front, take responsibility. Okay, things happen. Okay, document. Make sure that happens. A couple times, I can give you a couple other examples where that didn't happen. I'll give you one. There was a nursing home in this state, it's probably 4 years now, where somebody got insulin that wasn't diabetic, and the person died. Okay, that happens. Okay, and I still have never gotten, and we reviewed this case, I've never gotten the full story on it, whether the person ever really realized she gave it to the wrong person. Okay, I don't know. I hope she didn't, because if they called one of us, we would have said, hey, here's the deal. Okay, that's a long-acting insulin. Okay, check her blood sugar every half hour. Make sure that you've got juice or stuff or everything else available, because we would have guided her through that, and that wouldn't happen. Okay, those things happen. Okay, one funny story. You'll appreciate this. This isn't real. This is about right resident, but not totally about medication. I was at a QA meeting, and one of the administrators pulled me aside afterwards. I'd known him for a long, long time. He said, "I got to tell you the story." He said, "I had a resident who passed away this weekend. I had a float nurse in, and she called the wrong family." And so the family comes rushing down to the facility, and there's mom eating her special K. You know, so make sure you know who you're dealing with, okay? Make sure you know the right resident. And one final thing, don't trust your pharmacy. Don't trust anybody, okay? And here's why I say that. Okay, at one time in our computer, we had a Margaret booth, a Mary booth, and a Marion booth. Okay, and I'll get an order for M booth or whatever. And it's possible, it hasn't happened, but I could pick Margaret instead of Marion, fill that prescription, have it delivered to your place that night, and you go, oh, Marion's got an antibiotic, and then I go and give it to her. I don't check the med sheet, I just trust the pharmacy on the other side, okay? Go to the med sheet first, okay? Make sure, in fact, you go into that med sheet, okay?
That happens to my dad and my brother all the time because they're both Ed with the same last name. So they've had their medication switched a bunch of times.
I go to 2 different pharmacies. I really would. I mean, it happened. I mean, people are people. You know, we really do everything we can.
I taught at
put-
groups last week, but it wasn't the pharmacy, it was the physician.
That happens. We try to catch
Yeah.
those, you know, and
Yeah.
but we work together, okay? You know, you check me, I check you, I check the doc. I mean, we're all human, and we're all here for the same purpose, to help these folks take their medications right. So we work together, okay, to do that. But nobody's perfect. We have great systems in place to check things, but we're human, you know, ultimately, it's that pharmacist checking that bottle and that drug at the end stage. We use barcodes, but, you know, things can happen.
And it was ultimately me checking the med
Mm-hmm,
to the med book
yeah.
when it was, where it was caught.
To you
Yeah,
on the wrong
exactly.
strength or something, yeah,
Mhm.
yeah.
I
that
dealt
happens.
with, another job, I dealt with, charts, and we always had same name alert
Oh, yeah,
on the
Mhm.
chart,
Yeah.
so we were always told to check the date of birth.
yeah, that makes perfect sense, or.
But that
check
was a
you
heads
know,
up.
Yeah.
It worked.
Well, hospitals, it's really
I
weird,
thought
that
I was
you know,
thinking
if you've been in a hospital recently, and unfortunately, I had the pleasure of being in a hospital for 3 days this spring. But they barcode you in a hospital, but every time they come in, they ask you the same questions. I mean, even if it's 10,
Date of birth.
what you did at birth, I said, you just asked me that 3 minutes ago. And then, but they have the same procedures that they go through. So,
I put up with that for 3 days when I was in the hospital.
what's that?
I put up with that for 3 days when I was in
Yeah,
the
I
hospital.
did too.
Well, I stopped,
Well, but
It's the right thing to do. And they significantly have reduced drug errors in the hospitals. So.
when you have a baby, it's awful, because not only are they asking, what's your son's date of birth? What's your date of birth? I'm like, okay, you can fill out.
Yeah, and you've just given me Vicodin.
So please give me 5 minutes to sleep here.
Yeah. Well, I was in shock when I got in, so I couldn't answer too much at that point. So, go ahead.
I don't take my Synthroid in the dark anymore. I take Synthroid and I
Yeah.
take it on an empty stomach.
Yeah.
So I keep it right next to the bed with my
Yeah.
bottle of water, and when I get up in the morning,
Sure.
I just take, I know the Synthroid is there and I take it. Well, I also take lisinopril. Well,
Mhm.
this was quite a few years ago, but the pharmacy, and it wasn't yours, I didn't recognize this for 3 weeks later. They also filled the lisinopril with Synthroid. I had 2 bottles of Synthroid. So I was taking twice
So
the
your blood
amount
pressure was
every
going
day, and I'm wondering, why am I
Why am I wired? I can't sleep and my blood pressure's through the ceiling.